Welcome, everybody. We're going to get started right on time since we have 20 minutes. It's 10:59, so we're going to start with Dr. D'Onofrio. And thanks, everyone, for coming. We're going to make this really informal. We have a very short number of slides. We really want to just share our story and hear from you, questions, and inspire people to do this great work. So here's our inspirational leader.
Okay, here we go. And we'll be around afterwards a little bit if people want to talk because we know this is 20 minutes is kind of a little bit crazy. We don't really have any disclosures. These are our learning objectives so that you know we're describing our career trajectories and research training focused on substance use and emergency medicine and addiction and some successful programs and places for you to go and get some research and identify local services. I'm going to go over that. So there are many different training pathways to substance use research and ED programs and implementation. And so here are all the different types of things and fellowships that people can do. Obviously, addiction medicine is a fellowship. As you know, there's quite a few of them now around the country. They range from 1 to 2 years. Medical toxicology, which is 2 years. Pain and palliative care, which can be 1 year, maybe two, but I know people are doing it 1 year. And of course, there's a national clinical scholar program at multiple institutions where people have been through, and other research fellowships that people can do and sort of tailor them towards addiction, as well as there are K 12 programs. And we at Yale have a K 12 program funded by NIDA, and also the National EM Fellowship scholar program is open and funded partly by NIDA as well as NINDS. They will take one scholar who's doing something in addiction neuroscience, related to neuroscience. So that's another opportunity for young faculty members. And of course, then there are K-23s, individuals, and certain institutions have T32s, of which you can do a focus of addiction. So there are many places. So anyway, here are all of us. We're going to talk a little bit, and I'll just say my path, which was very circuitous, and I've been around for a pretty long time. So it I was in the first residency program at Boston City Hospital, so we started that way. A lot of people with substance use got a lot interested, and my main mentor, Jeff Samet, in internal medicine, actually had a SAMHSA grant for fellowships and research, and he wanted a different person from each specialty, and that's how really I got into more formal research training through him and all of his group there. I then came to Yale, and I have done a lot of research in substance use, and then I just helped develop the field of addiction medicine, quite truthfully, and was on the board of that, representing you all as emergency physicians. And then we were able to, after probably a decade of work, get to have the field of addiction medicine. And this is the last year that people can apply in the practice plan. So if you haven't already done the work, you most likely cannot do it by now. But we are just finishing up approving people to take the exam for this year. Other than that, you'll need to do the addiction medicine pathway, and we can talk more about that later. And I think we should move on. Dr.
Thanks. So really briefly, I'm Jean Marie Perrone. My pathway was I did a medical toxicology fellowship at Bellevue. At the time, there weren't a lot of people using, there were small populations. It was pre-opioid crisis, let's just say. So mostly I wrote toxicology case reports and then shifted into opioid deprescribing work, and then ultimately picking up the pieces of the addiction crisis in like 2015. And then I copied a lot of the work that Gail, then Andrew did with starting ED buprenorphine. And so I started a program at my hospital around 2017, and then ultimately got boarded in 2019 in addiction medicine. So there's many different ways to do this, but I think that the intersection, just like the room, and I should have made a slide of all the addiction presentations at this meeting because there's just a tremendous amount of shift and interest. This is, we're emergency physicians. We go to where the needs are, and that's really what the pathway for all of us. So Andrew, if you want to share a little bit.
Yes, my basically before med school, I did a lot of public health work, so starting programs. So that's kind of, I'm really basically on the implementation side of things. So creating new programs. And then as I started creating new programs, I, I, should I, are we going to go into our slides? Just do the pathway. Okay, got it. So basically, I build stuff, and um, there's a lot of needed Highlands. So we got going and kind of got going on a big scale, and I just reached out to everyone I could find who for help, and connected with Gail, and then connected with Kate and Jean Marie, and it kind of all went off from there. But it was basically built on a core of implementation. So I guess that would be my distinguishment from the group. I didn't do a pain management fellowship. I grandfathered into that. It's a long story there. They so No, I have a board certification, but basically what happened is my crazy hospital, there was a guy who ran a big pain clinic and was a wonderful guy, Howard Kornfeld. And he had a bunch of people on opioids and buprenorphine. He was an early innovator in like 2012 through 15. They fired him for no good reason because he was the team trying to save Prince. Do you remember all that? Right? So he was the good guy. He was a hero, but the media looked bad, so they fired him. And I was the only person in the health center with a waiver. So the next day, I got nominated to run the pain clinic. So, so I said, okay. And I used that to be like, come on, I run a pain clinic. You got to let me sit for the boards. So that was my path.
My name is Kate. I'm at Yale University. My path, I mean, obviously, I developed a little bit behind these guys and got to stay on the shoulders of giants. I moved to New Haven for residency in 2010. After going to medical school in Philly and working at Prevention Point Clinic up in Kensington, draining abscesses and handing out Bactrim, and was like, I want to go do addiction stuff in the ED. And somebody was doing it. She was doing it better than anybody else at the time. So that's how I wound up at Yale. And then stayed on for she established a K-12, which is an interdisciplinary career development program for folks who are emergency medicine, internal medicine. We've had OBGYN, pediatricians, and so it's a 3-year career development award through NIDA. That includes research training, and then also, a little bit of money to sort of do projects and things like that. And so most of my work has been around implementing OUD treatments from the emergency department, mostly focused on buprenorphine, and also some work around implementing medications for alcohol use disorder in the ED. And then I think for that, we can just go ahead and move forward because I want to make sure we have time to do all the things. Okay, so one of the things that is always, when you think about doing research and doing implementation research, the real question is sort of where is the money going to come from to do this? Because we know we implement a lot of clinical quality improvement initiatives and things in our emergency departments, but a lot of times external funding is really important in order to build programs, to hire support staff, and certainly if you're going to do sort of data collection, data analysis, and things like that. So, I mean, obviously there is there is federal funding, most primarily through NIDA and IAAA, around, initiate, if you want to evaluate or implement research around substance use disorders. There's also SAMHSA funding, which I feel like a lot of people have been able to use and leverage. Also want to highlight, particularly in the wake of, some impending changes around NIH and NIH funding. There are definitely a lot of foundations who are also really interested in supporting this work. So Robert Wood Johnson Foundation for Opioid Response has actually been a very good partner for some of our work that we've done through ASAP around implementing quality improvement projects, and really in community and critical access EDs. So Arnold Ventures has funded some interesting sort of off the cuff harm reduction stuff. Pew, Vital Strategies, and then I'm not sure who Dale and Lucy Packard are or how they wound up here, but anyways, the point is get creative to help build your project and your evaluation. And it's, obviously NIH funding is wonderful, but it takes years to go from sort of concept to dollars in hand and being able to hire. And then after that, you're still years, to present a project. What Gail presented at the plenary yesterday was, I think, a protocol that was made in 2018, funding that went in probably 2016 or 2017. So it takes a really long time to sort of get those projects up and running. Andrew, do you want to talk about state funds?
So I guess the point of this is just to kind of understand how stuff is funded in the real world, and it's not intuitive at all. Every state's a little different, but there's some commonalities. So basically, public health departments will do overdose deaths and naloxone, right? But they don't do any treatment. So they don't do medication-assisted treatment or behavioral treatment. So there's this whole sort of line of partnership and funding that has to do with just basically tracking deaths and doing naloxone and harm reduction. So that's like one bucket. Then there's the behavioral health departments. And so in most communities, behavioral health departments and medical systems have a completely different set of funding mechanisms through Medicaid or wherever, a completely different governance. The advantage of behavioral health is potentially controllable, meaning there's a cascading set of requirements that the state can say, you need to do this, you need to have equine therapy, or you need to have methadone, or you need to have buprenorphine. You can tell that system and bake it into your grant, you need to have those things. The problem is typically the footprint of that system is going to reach like 5% of the population of people living with disease. So then in the middle are the health systems. So the health systems might encounter and have contact with 80% of the people living with disease. But health systems are fundamentally uncontrollable. Like there's really no way to have any kind of top-down control of what a health system does. The managed care plans are very politically powerful and will fight you on any change in terms of benefit structure. And then the hospitals themselves are also, very wealthy and will fight kind of anything, kind of own joint commission on the back end, so you can't really use levers of metrics to control. So they really are literally uncontrollable. So if you're trying to do a new thing, you have to really figure out you have to find the incentive or the self-interest for each one of these groups and cobble them together so that they can find some way that you can use the health system to benefit the behavioral system that will then pay you to nudge the health system to do something. So the way the actual sort of buckets that this rolls out is opioid settlement funds, often will go from state to county. So that's that behavioral health program, right? So that's that idea of this small footprint entity that will have this big chunk of money potentially. These are the state opioid response funds that roll out from the feds, and then they go down to your state level. And I've seen really differences in terms of if they go to counties. There's a lot of, I would say these had the most degree of freedom, so you can kind of go after those. We're on the 4th round now. We don't know if there's going to be a 5th. Health departments, like I said, they're very low income in general, and they're really focused on naloxone and opioid overdose deaths that don't typically have a lot of money to do treatment unless you're in a unique city where the city contributes and supplements them, but at the state level they typically don't. And then behavioral health systems, like I said, they're the ones, like if you're an alien flying to a region, you say, who's in charge of people living with substance use disorders? They're going to point you to director of the county behavioral health system, right? But behavioral health systems don't have doctors. They just don't. They have counselors and LCSWs and residential treatment and like a few doctors. So there's this huge gap, bringing together the health system and the behavioral health system. So that's like, if there is a fundamental opportunity to create innovative programs that could potentially draw down money and fund it and then evaluate and produce research on them, it's figuring out how to bring together health systems and behavioral health. That's my spiel.
That's wonderful. Okay. All right. So moving forward. Obviously I alluded to sort of NIH funding that before that, we all certainly know about it. It exists. The real question is sort of, how you go about pursuing it and really sort of who needs it. So this is a slide of increase in emergency medicine, NIH funded K08 and K23s, which are sort of training awards. K08s tend to be basic science oriented, not necessarily involving human clinical trials or human subjects, and K-23s tend to be much more common in the emergency medicine field. As you can see, but clearly you can do both. And so, I mean, clearly we've made big strides in sort of emergency medicine physicians who have received K-08s and K-23s from NIH and AHRQ over the past 20 years. It was very, very, very uncommon before. And so, there are lots of, it happens to be that none of the four of us actually wound up taking the K-23 path. I did a K-12, which goes to the institution, which means Gail applied for it. Applying for your own K-08 and K-23, which I imagine many of you have done in the room, is definitely a very involved process. You definitely need you need a good mentor team. You're going to want to have some experience, and their SAEM has a lot of sort of grant writing courses and things like that that can help you put those together if you're interested in pursuing that. Other research training opportunities. We've talked about the K-12. Certainly the Yale drug use, addiction, and HIV scholar K-12 was just renewed for the third 5-year cycle. So that exists. I think they have space for maybe 2 scholars a year. Sometimes they're emergency medicine, sometimes they're not. Okay, 1 a year. But the NIH funding is, we're crossing our fingers that it continues to come through. And then K-23s we talked about. T-32s, are similar to K-12 in the sense that they are, really held within the university. And so, Gail, did you want to say anything else about T-32s? Other than
you should find out if you have them in your institutions, and often they really struggle to get people to join the T-32s. T-32s do not have money for faculty; it all goes to the applicant, and often they do so. For example, we have one in aging at Yale, but if you want to do something substantive in aging, you can get in, right? So you just have to kind of look for it. If people aren't looking for it, then you won't even know that it's there. But it is a definite possibility. It will give you funding for your time. It will give you funding for educational needs or formal research training, etc. So they are. I don't know if they're great things to have. We had them in NHLPI. People struggle to get people in those T-32s. I know, having talked to a lot of people who had them, or to continue them, but if they are available in your institution, you should look into it because it could be something you don't even know that's available.
Well, and similarly, it's not up here, but KL2s and CTSAs are the other things that many institutions have that you should look out for. And you can certainly, there's no reason that you can't, apply for those with an addiction focus. I know the one at our institution tends to be more basic science heavy than clinical science, which, but it's certainly something to, you want to look for all of the potential funding to help support if you are, want research training, which you definitely don't have to have research training in order to do research in addiction. But if you're gonna, yes, but I don't know if you can hear her say, she's saying you should. Obviously it's another thing. And then do you want to talk about RAMs at all? So it is a program that exists. It's Research and Addiction Medicine Scholars. It is a program that exists. It was started by her mentor that she mentioned earlier, Jeff Samet, up in Boston. And it is a way to sort of integrate a longitudinal research mentorship that can be at distance over the course of a year. With that, you'd be paired with a research mentor, and it sort of goes over the course of a year. And so it's a way to sort of, it is definitely not research training with a capital T, but it is like, the ability to sort of reach out to somebody and be paired for a mentored project and get a little bit of exposure if you're sort of trying to dip your toe into research, training and experience without having a lot of local resources available to you. Other things, this is just the K-23 and K-08s from emergency medicine clinicians that are broken up by institute. This is from 2024, but certainly you can look and see that, NIDA and NIAAA are very tiny. So, in theory, there should be lots and lots of opportunities for developing emergency medicine trainees, and clearly there is very much a need for ongoing developing expertise in this field. So I'm going to stop right there. I imagine there are people that have questions. If anybody has questions, I'm going to sit down because I've been talking a lot, and I'm going to let you guys run that.
I know that there's a lot of people in this room who have diverse training pathways, and I can call you out, or I don't know. Carrie, did you do a fellowship? You know, tell us a little bit about your work and where it's getting funded from, and thanks. Kit, you want to say something about your background? I mean, there's a lot of people with like research training who then brought in the addiction as a focus. Yeah, has a really nice portfolio of many big grants focused on a lot of different things. We've been working together on an alcohol use from the emergency department, naltrexone initiative that's really relatively not funded, but still is just like good stuff to do. It's a good way to get you know, pilot data to apply for bigger grants. And we're talking to some of our other colleagues around the tables here about, you know, writing a big multi-site grant for something like that. Other people want to share or ask questions? We're really friendly. You must be here for a reason. We don't have all the secrets to getting funding, but you have a lot of people here who have applied and not gotten lots of funding, which you also learn a lot. Ryan, you want to tell us something? I didn't mean to call on you for that, Ryan. You want to tell us who you are? I'm sorry. Thanks, Ryan. Jason?
foundational grants and now finally have an IDA, R61, R33 that's been a culmination of those other small pieces. So it's a little bit less traditional, but I think the benefit of doing that is that you sort of learn a lot about what you can and cannot do, and you have structures in place. So when things turn around quick, like there was a discussion this morning about NOCs from NIH, which are these really quick turnarounds. If you have a lot of the programmatic stuff in place, you can cobble together pretty quickly everything else. And like the state grants that they put out in Colorado, at least, they're put out the same way that they put out an RFP for like garbage trucks. Like it's like you got 2 months and like you just apply. And that's not the way we work. But if you have that stuff ready, then you can bang it out and nobody else can do it. And so there's I think benefits to having the structure in place rather than trying to do it all at once. So
Yeah, we're gonna run out of time.
Yeah,
so,
we're out of time,
we are
but that's okay. But you guys can stay or go. We said we'd stay around for questions. So
I just want to be clear is that if you're young and you're starting out versus a junior, whatever the word is, if you're a young investigator or trying to be a young investigator, then you should get the formal addiction training. Don't go into addiction medicine without formal training. So you need to do it because you're not going to get funded unless you do, or you'll have a huge team around you who are going to do a heavy lift. So it's much easier to do it when you are in the beginning stages of your career than going back and doing it. So that you should plan that into whatever you're doing. There's lots of stuff out there. I can tell you that what I think is going to happen, but I'm going to tell you, can't tell you why I know this, but there's going to be probably less general PAs out there. And so they're going to be mostly his money, although it's not really being horribly reduced, but it's not going up, and you never know. But they're going to be these kind of RFAs or things that the institutes are really interested in. You should look at those things and make sure what you're putting in is around those institutes' real priorities. And not just answering general PAs. There's mostly kind of general program announcements out there. You can just say, well, I can fit my thing in there. You have to just be sure that you are answering really what their top priorities are, because that's how they will fund you. And it's good to just keep looking at them now. So when you think about something or if you're collecting data, you know this is kind of like a priority of that institution, so that they're going to stay in those priority ranges, and so that you're ready. Just like you said, there probably won't be very many general PAs.
Gail, I have a question for you. Do you know how many EM addiction medicine boarded people there are?
I should know that, but I don't off the top of my head. I really don't. I should know that. I don't.
There's many and a growing number, and
We're a tiny piece of the pie.
of the addiction medicine pie.
Of the addiction medicine.
Yeah.
There's another session starting in 2 minutes.
Oh,
so
outside.
we'll be
Okay.
outside if you want to
Okay.
chat.
Okay.
Thank you.
Thank
guys for
you.
coming.